and today I'm going to give a talk about the management for unexplained infertility. Here are my conflicts of interest. And let's start with the question, why infertility is more relevant today? Well, it's more relevant today because obviously our patients are coming to us older. For instance, the mean maternal age in 1970 was around 25, while in 2010 was almost 30 years of age. And we know very well that fertility declines with age. So pregnancy rates decrease with advanced maternal age on one hand, and on the other hand, we have miscarriage rates that also go up. You know very well that infertility is defined by the failure to achieve a pregnancy after 1 year of unprotected sexual intercourse. So one limitation of this definition is that age is not part of the diagnostic criteria for infertility. Although we know very well that ovarian reserve, for instance, AMH and AFC, like Professor Maghrabi presented in the previous lecture, decrease with age. And I would say it's striking that the diagnosis of unexplained infertility is given more frequently in older patients. For instance, in this study, you may see that patients above the age of 35 were labeled with a diagnosis of unexplained infertility more frequently compared to patients below 35, something that, of course, does not make sense. And this is just a mathematical model showing how wrong we are when we give the diagnosis of unexplained fertility to a patient of 42, 43, or 44 years of age. I think this is a very important slide. We know that AMH, as I said before, declines with age. However, AMH cannot be used in patients that are not infertile. So this study, this prospective study published in JAMA 3 years ago, found that there was no association between AMH levels and chances of natural conception. And this is a very important message for our patients because very often we see patients in our office referred by their gynecologists because they have a low AMH, patients that are not infertile. And it's important to let them explain, to explain to them that if they have a low AMH levels but are not infertile, there's no reason to go for IVF or do an infertility treatment. Although there is some evidence that is controversial, that there is a relationship between low AMH and early menopause, but again, the evidence is controversial. So we have an infertile couple, and based on the diagnosis, we can propose the appropriate treatment. For instance, if we have a patient with semen abnormalities, surgery or some injections could be the solution. If we have a female partner with tubal or uterine disorders, surgery may be indicated. In case of a patient with PCOS, clomiphene, letrozole, or gonadotropins could be an option. And in case of unexplained infertility, as I said before, that represents approximately 25% of cases of infertility, expectant management could also be suggested in some cases, but it's something that I will discuss in the next slide. And of course, assisted reproductive technology, either in the form of IUI or IVF, could also be an option. So a crucial question is how we can evaluate, how we can assess the prognosis of an infertile couple. And this is a crucial question. So for this, we have this model, the Honor prediction model is a model that was published in 2004. And this model, I present this model because it's taken into account in all well-designed randomized studies comparing different options in patients with unexplained fertility. So this model takes into account several parameters. So it takes into account female age, duration of infertility, whether we have a patient with primary or secondary infertility, sperm motility, and whether the patient was referred to us by her own gynecologist or by a general practitioner. And based on these parameters, we get a score that gives the chances to have a baby following over the year following the fertility workup. And if we have a patient that has less than 30% of chance to have of natural conception, this patient is classified as a patient of bad prognosis. Of course, this is a link where you can play around and put the values of your patient and get a score and the prediction, so you can give this to your patient. So let's start with a young infertile couple. Should we use, with unexplained infertility, of course, should we use clomiphene to this patient? So the answer to this question was given by Bhattacharya in 2008 in a very nice randomized study, where he compared expectant management with clomiphene for 6 months. So almost 600 patients randomized. And based on the results, it seems that there is no difference in live birth rate. So there is no reason at all to give clomiphene to your patients with unexplained fertility. And I need to highlight that because, again, we receive quite often patients with having clomiphene for several months before coming to our office. There is no reason to give clomiphene to these patients with unexplained infertility. Could IUI, could insemination have a role? Well, it depends on the prognosis of the couple. So again, I talk about young infertile couples. So this randomized study compared expected management with IUI in the form of gonadotropins. So 252 patients randomized, mean female age 33, 2 years duration of infertility. As I said, the prognosis was intermediate, so the prediction score of natural conception was above 30%. And based on the results of this randomized study, it seems that there is no difference in ongoing pregnancy rates between expected management and IUI. So yes, if you have an infertile couple of, let's say, good prognosis, a young infertile couple of good prognosis with unexplained fertility, you can maybe wait 6 months before going to more advanced techniques. On the other hand, if we have a young infertile couple with unexplained infertility, but which is of bad prognosis this time, things change. For instance, in this randomized study of Cynthia Falkuhan from Australia, compared expected management with IUI combined with clomiphene citrate or letrozole. And in this randomized study, the couples included had the bad prognosis, so prediction score of natural conception less than 30%. If we take a look at the results, it seems that IUI results in 3 times higher live birth rates compared to expected management. So for these patients, IUI has a role. This is another prospective cohort study replicating the results of the randomized study. Again, if we have a couple of bad prognosis, IUI results in higher pregnancy rates compared to expectant management. Could IVF be proposed to a young infertile couple? Should IVF be the first line treatment to a young infertile couple with unexplained infertility? Well, this well-done randomized study compared 6 cycles of IUI with 3 cycles of IVF. 600 patients randomized, patients below the age of 38, bad prognosis patients. And the authors found that there was no difference in live birth rates between IUI and IVF. Okay, so this shows that in fact there is no reason to go directly for IVF if you have a patient, a young infertile patient with unexplained infertility. Similarly, if we compare 3 cycles of IUI with 1 cycle of IVF for a young infertile couple with unexplained infertility, ongoing pregnancy rates are quite similar. So again, there is no reason to go directly for IVF. However, one might ask, and I think is reasonable, why don't go for IVF, given that we get my patient pregnant earlier? And I think it's a good question. But fortunately or unfortunately, many things in life are a matter of money. And the authors of the previous study made a post hoc analysis, a cost-benefit analysis, and found something that is expected, that one cycle of IVF costs approximately €900 more compared with 3 cycles of IUI. So actually, if we have a patient that cannot pay for IVF, there is no reason to go for IVF as first-line treatment. Another question that they asked me, Dr. Drakopoulos, how many cycles of IUI should we perform? Well, I would say in general, we should not exceed 6 cycles. Why? Because cumulative live birth rates after 6 cycles of IUI reach a plateau. You see, we don't have an increase in cumulative live birth rates after 6 insemination cycles. And in most cases, you will have the couple in front of you that gonna say, "Look, doctor, I want to, after 3 cycles, if after 3 failed IUI cycles, they would like to move to a more, let's say, advanced treatment like IVF." When to perform the IUI? In my center in Brussels, but also in Greece, we give HCG, and we do the insemination 34 to 36 hours after the HCG injection. And in other centers, they do it maybe the day of HCG or some hours afterwards. And this study found that it's correct. In fact, there is no difference in biochemical pregnancy or clinical pregnancy rates between patients having the insemination with HCG and patients having the insemination 34 to 36 hours after HCG injection. Should we do 1 or 2 HCG inseminations per cycle? I think that there is no reason to go for 2 inseminations. In fact, there is no difference in live birth rate. 1 is okay, because otherwise also we increase the emotional burden of our patients. So in general, I would recommend not to go for 2 inseminations in the same cycle. Stimulated IUI cycles or not? This comes from New England Journal of Medicine, the Amigos LCT, that found that if we give gonadotropins, we increase clinical pregnancy and live birth rates compared to clomiphene and letrozole. Again, I know that there are some other studies showing no difference, but we need to keep in mind that if we give gonadotropins along with the insemination, then we take some important risk. That is, of course, the risk of multiple pregnancies that increase in case of gonadotropins. So please, if you give gonadotropins to your patient, you need to perform a close monitoring of your cycle, and even be ready to cancel the cycle if you have more than 2 follicles in the ultrasound. And when should we switch from IUI to IVF? Again, I talk for a young infertile couple with unexplained infertility. And this randomized study compared conventional treatment, so with three cycles of IUI with clomiphene, followed by 3 cycles of FSH with IUI, and up to 6 cycles of IVF. This was the conventional treatment arm. And in the accelerated treatment arm, patients had 3 cycles of clomiphene with IUI, and in case of no pregnancy, they moved directly to IVF. So there was no insemination. There was no insemination with FSH. The mean female age was 34, and in fact, what they found, the authors, was that pregnancy rates were 1.25 times higher in the accelerated treatment arm, and also the median time to pregnancy was shorter for the accelerated treatment arm. So if you have, so the message is that if you have a patient, you start with clomiphene and IUI. If after 3 cycles the patient is not pregnant, there is no reason to give FSH and go again for insemination. You can go directly to IVF in order to increase the pregnancy rate and also have your patient pregnant earlier. Let's now move to an old infertile couple. I think for this category of patients, things are more clear, and are more clear because we have this nice HCT from 2004 fertility paper comparing IVF with 2 cycles of IUI in patients over 38. And if we take a look at the results, live birth rates were more than 2 times higher for IVF. So if you have a patient of 39 years old that comes to your office, it's better to go directly for IVF and not lose time with inseminations. Nonetheless, IVF does not offer miracles, and this is something that we need again to transmit to our patients during the consultation. Because if we compare IVF with expectant management for a patient who is 42 or 43, you see that there is no much difference. So if you have a patient of 42 or 43 years of age, you should discuss, of course, the option of egg donation. And you should explain to your patient that even if you perform IVF, live birth rates will be very, very low. This is a slide for general gynecologists. So just for those that do not know, in IVF, all sites are fertilized with sperm in petri dish, while in ICSI, a single sperm is injected directly into an oocyte. And IVF could be used for several indications. However, ICSI should be used only in male factor infertility. And this is another important message because, again, very often we have patients that have performed IVF in other centers and had all the IVF cycles with ICSI, although there was no male factor infertility. And I think this year also in EFRE there was a very nice presentation, the results of a very nice randomized study from Vietnam showing no difference in fertilization rates and live birth rates between IVF and ICSI. So in order to treat our infertile couple, we need to take into account several characteristics like the age of our patient, the vital reserve, AMH, AFC, parity, BMI. If the patient had previous cycles in another center, we need to know the response to ART. And based on these parameters, we choose the most appropriate treatment protocol for our patients. And of course, the most important step during IVF is the creation and selection of a high quality embryo for transfer. So embryo quality plays a crucial role. However, something that is not obvious for all patients, because as we said before, age affects both oocyte quantity and oocyte quality, so affects also embryo quality. So based on the vital reserve, we can choose the appropriate protocol. So if we have a poor responder, so a patient with low AMH and low AFC, our goal should be to maximize, to increase, if possible, of course, the number of oocytes retrieved. If we have a normal responder, then standard treatment could be suggested, and the idea is to maximize success rate. While when we have a high responder, for instance, a PCOS patient, then our goal should be to minimize the risk of OHSS, which is an iatrogenic complication. So I would like to reach the conclusions of my presentation. Age plays a crucial role and affects both oocyte quantity and quality. I think this is clear for everybody. AMH is not related to the chances of natural conception. This is an important message. Clomiphene has no place in unexplained infertility. The hormonal prediction model could be used to assess the prognosis of an infertile couple. In general, IVF offers better results compared to expectant management or IUI, but of course, the cost of IVF should also be taken into account. IVF should be the first line treatment in older women, so in women over 38. And the management of fertility is individualized, taking into account different parameters like the cost and the burden of the patient. I would like to thank you very much for your attention.